So it's such a pleasure to be part of this organization and to be invited to talk. But I want you to think of my lab as a little Silicon Valley style startup centered smack in the middle of Connecticut in the forest. And there we ask a lot of questions. So I do have some disclosures. I do clinical trials in PET imaging, and I have a non-compensated research collaboration with Visage Imaging, but highlight non-compensated. So this is a problem that is seen a lot, and this was one of the neuro-oncologists at Yale who reached out to me, and he said, "You know, Miriam, I can't understand the radiology report. It doesn't make any sense. And looking at this tumor, it's a pilocytic astrocytoma, and I'm trying to figure out whether I should change therapy or not. Can you please tell me whether there's progression or not?" And when you look at this case and you can see current and prior, and you look at these measurements that are done on impacts, your mind starts to get really upset because which one do you use? Which one is the correct? So this is what I started looked further in this particular patient, and this is actually individual treatment days for this particular patient over time while they're on therapy. And these are actual measurements, impacts of this tumor in a child who is being treated with pretty significant chemotherapy, and we're trying to determine treatment response based on this. And as you can all agree, this is not the gold standard. So I actually started doing this at Yale when I joined there after fellowship. I pull out my Excel and I start doing the volumetric measurements for Dr. Marks. And it takes me a couple hours to do, but I feel strongly about it. And this is that particular patient, and these are the kind of treatment response curves I provide for him. And that does help him in deciding whether to treat the patient or not, as you can imagine. But I don't stop there because I'm obsessive compulsive. I also do solid portion and cystic portion, and he really likes that. So now I get a lot of emails about doing these kinds of things. But, there's only so many hours in a day. And luckily, we have a very low volume of pediatric brain tumors at Yale. So we need to scale this up. So volumetric measurements are not provided in clinical practice. It's just because I really believe in it. But if you try to do this at another institution, the neuroradiologist will just not answer your emails. The reason is majority of PACs don't have the platform for the measurements we need. We just don't have that. And the kind of neuroradiology workflow is pretty intense. So to do the measurements, to do it in a machine learning application type of way, you would have to download the DICOM, upload it into segmentation software, perform the segmentation, and only then you can export the segmentation with a Nifty file so you can have your volumes and you can have all your radiomics features. That's really not clinically feasible. That can take up to hours, sometimes days. So you really need something within the clinical PACs, volumetric segmentation tools within clinical PACs, so you can actually automate this in the clinical practice. And this is what we developed at Yale. So this is what I used to do when I was a fellow at another institution. And you can see this can take forever. This is actually speeded up by 8 times. And it does take extremely long amount of time. I'm just going to turn that off. That's really Avicii. Basically says, wake me up when it's all over. And that's exactly how I felt about segmentations. So we don't do manual contouring anymore. We actually worked with our PAC system, and I do agree with industry collaborations. This is very true, Dr. Wonders. We started talking to them, and they talked to us back. And they developed this platform for us where you actually have machine learning tools plugged into our PACs, and you just press the button, and the unit algorithm will auto-segment your tumor. It took us 2 years to do. Don't think about it, but now it takes 4 seconds. So here's the buttons. You push the button, a unit algorithm that's trained on the Bratz data set, it gets activated. Now we're mostly adult, that's why Bratz data set. In 4 seconds, you have your segmentation. and it appears in every single sequence on a platform. Then you can actually push another button and you have features extracted. And then you can actually send those features and do machine learning. And that's how we built a 1,000-patient glioma data set on zero funding in my lab, on no startup time, no nothing, and just medical students working with me and me checking the segmentations. We now have IDH classification algorithm and high-grade versus low-grade glioma algorithms that we're plugging in. And it's on the same platform that's used in my reading room. So I can just easily incorporate this into my reading room, and we're running the clinical trial right now. So what I built is we have this network for collaborative discoveries, which is based on data sets, algorithm tool development, and clinical trials. And it's all because of this relational database that links imaging to clinical data, and it can be used for research, education, and clinical practice. These are the databases we built on zero funding as a junior investigator, right? And this is just because we communicate well with industry and with students, and we really focus on growth of the students. We have the auto segmentation algorithms are actually going into full clinical production this December at RSNA, and going to be available to anyone on the same platform, PACS across the US, including CHOP. So I'm very excited to be coming down and working with you guys. And these are the trials that we're running right now. But, and we finally got this published. It took us forever, 18 months, but this just came out in terms of how we built the API, incorporate the API, and did this 3 auto segmentation algorithm into a PACS. We also focused on treatment response assessment over time. So this was published recently, and this is basically the kind of treatment response curves we now provide regularly to our clinical providers in clinical practice. And what was really amazing, and these are gamma knife treated brain mets in adults, we actually now are separating RANO-BM criteria in progressive disease into 2, homogeneous response and heterogeneous response, because you can imagine this patient will be treated very differently than this patient, right? So this is now available in clinical practice. Future is now. And this is what's so exciting, Dr. Resnick. I love this. We've done this. We have FHIR forms incorporated into our PACS. So the idea is to take your images and to actually pull the data and from the electronic medical record, or actually modify your own data into and basically link it so that your DICOM data is now talking to your EMR data. It's possible. I'm having trouble publishing that paper, so I would love your advice. JAMA did not like it. So, overview of, so how did we apply this into PNOC trials? I was lucky to start working with Sabina when I was a resident and fellow at UCSF. And I was involved in treatment response assessment for PNOC001 and 02 trials. But first, let's go over a little bit about in terms of how we did the measurements. And as you remember, the McDonald criteria in 1990s, the RESIST criteria in 2000, where we used the longest diameter, the RANO criteria in 2010, which started including the flare in assessment, but there was always an elephant in the room where, in terms of pediatrics response criteria. And at that time, most clinical trials were only using RANO criteria for pediatric LGG and HGG, and that's actually the criteria that we were using in terms of modifying complete response, stable disease, partial response, and progressive disease. And it was really exciting to see the RAPNO criteria come out in 2020, because we finally had assessments for children, which addressed issues of focus on functional and additional issues that are important for pediatrics, with focus on functional outcomes, incorporation of cystic component, which is a big issue in pediatrics, recommendation for imaging protocols, and increased role of FLAIR and T2 imaging, and introduction of minor and major response. But there was still a small elephant in the room, even after the RAPNO criteria, because pediatric tumors will have variety of shapes and changes in enhancement after treatment, which is a big issue. Response in cystic component is very difficult to monitor. And the leptomeningeal seeding, how do you measure that? That's really, really hard. And if you're segmenting this, that can take like hours. So we were interested in developing volumetric, semi-automated volumetrics in pediatric, in PNOC001 and PNOC002. But unfortunately, our adult algorithms didn't work, which is expected, right? And luckily, we have Dr. Nabavizadeh and Dr. Anahita Fadi-Kazaruni sitting in the room where they have an algorithm that works. So it's really, really exciting. So we actually manually segmented and semi-automatically segmented with manual. Majority of the ones were manual, and worked with Dr. Sarah Bruni from Zurich to do longitudinal volumetric assessment. We looked at T1 post-contrast, T2 and FLAIR images. We did the volumetrics in our PACS interface, and we compared to 2D measurements from the clinical trials. Now, the problem that we had is we really didn't have the gold standard for determining the cutoffs, because pediatric low-grade gliomas, overall survival is not available usually. Luckily, these children live a very long time. Progression-free survival doesn't work because it's based on 2D measurements. So you're going to compare 2D measurement to a 2D measurement type assessment, right? That works. So we compared it to radiologist assessment. So basically forcing a radiologist to make a decision, which is sometimes very hard, as you all know, but we forced them to make a decision with BT RADS, which is a classification method. And we compared it to that. I would love to compare it to visual assessment as a much better endpoint, but that would have to be in optic pathway gliomas. We also calculated response cutoff analysis just because we need to get the paper published, but we do understand that there's no true gold standard. And then Sarah did this amazing work on case-based response modeling, which I think we'll try to incorporate into our PACS because it's really cool. These are the results in terms of the cutoff assessments that we got based on BT RADS, so radiologist assessment. And if you look at volumetric change of 10 to 15%, it's giving you really nice sensitivity and specificity for progression of disease. So you no longer need to wait for 25% increase in size to class. So it actually classifies progression of disease earlier. Once again, our gold standard is not true gold standard. And then when you look at this Sankey plot, and this is actually great that this is in Washington, D.C., because this kind of plots are used in politics a lot in terms of voters switching parties, right? So here we have tumors switching their response assessments. If you can see that there's a lot of switching going on between 2D RAPNO assessments, BT-RADS, which is the radiologist assessment, and 3D solid volume, maybe a little bit less between the 3D solid volume, but which one's the truth? We don't know yet. I think this would be really great to assess in high-grade gliomas where we actually have overall survival as an endpoint. But basically it's saying that these are giving different results. And then this really exciting response modeling by Sarah Bruni in terms of classifying these tumors into different types of responders. So we have the 3 types of responders. And I think this is really helpful for clinical practice because then you can actually see where you want to be switching a patient from therapy or different therapy. So future directions, we have a team. Mark will continue with us, Sarah also, and Divya just got a grant from RSNA to do this work. So she's a medical student. So we're planning to do response modeling using extracted tumor features. So Sarah's running that right now. We want to incorporate pediatric specific auto-segmentation algorithm into PACS, and I'm really excited to work with Dr. Nabavizadeh on this. We're doing PNOC002 measurements, and we are incorporating all of this into clinical practice. And also, it would be really neat to collaborate with leaders in federated learning methods to really start making this open data science into challenges in terms of identifying future directions. Now, PNOC002, we're doing a little differently than we did PNOC001. PNOC001, we had the separate Excel sheet with clinical data and packs with we're not doing this anymore. Now we have FHIR. Granted, I'm trying to get a grant on FHIR forms, but we are actually putting all the data into the FHIR forms with the imaging. So, and the nice thing is you can export, once you can highlight all of your cases and you export a CSV file with all of the data whenever you want and whenever you change, which is really, I swear, our paper that we did for CDKN2A prediction, it took us a fraction of the time than it would have taken us if we use traditional methods. So this is the quantification of the fraction of the time. So what can you use PACS-based tools in oncology for? Well, volumetrics is fantastic, but then you can also get, because it's a segmentation, you can get features out of it, and you can start doing classification based on what you're interested in. You can do treatment response curves. You can study tumor heterogeneity and finally targeted biopsy. And since I'm a nuclear medicine physician, you can start doing dosimetry, finally, which we desperately need in nuclear medicine and are not doing yet. None of this work would be possible without these amazing medical students who come and work in my lab. Some of them are high school students, and they just create this amazing atmosphere. So I was able to recreate a little bit of San Francisco in Connecticut, and it's been really fun. And I also just discovered Philadelphia, which is unbelievable. So thank you for including me in the Brain Tumor Avengers. That was the best run ever. And Rocky Balboa is right there. So just want to thank this group for making science fun and really re-energizing my efforts.